We have two phenomenal guests with us today. First, Dr. Qudsia Khan. Dr. Khan is the Chief Medical Officer at Northwest Integrated Health there in Tacoma, Washington. Dr. Khan and her staff were were the first group where we implemented our managed MAT program, and they really helped us develop the program early on. In fact, they were so successful with this program that Dr. Khan co-authored a study that was recently published in the Journal of Substance Abuse Treatment, demonstrating that patients in Cordant's program had higher adherence rates and improved outcomes overall. We also have Dr. Chris Harlow, who's a PharmD and the Director of Pharmacy Services for us here at Cordant Health Solutions. Chris is going to talk a little bit about Cordant's programs, removing some common barriers that are out there, as well as improving access to MAT medications such as buprenorphine and Vivitrol that are so important in the treatment of substance use disorder. So with that, after we get through talking with those two, I will give a very brief overview of our program and how it works, and then we'll open up things for questions. So with that, let's get started. Dr. Khan, welcome. Thank you for spending some time with us.
Thank you, Bob, for the invite. It's always a pleasure.
Yeah, great to see you. Why don't you tell us a little bit about yourself, Dr. Khan, and your role there at NWIH?
Sure. So Bob, I'm a internal medicine doc by training. I have been practicing in Pierce County for about 12 years. And my focus shifted to addiction medicine about 7 years ago when I saw a lot of my primary care patients struggle with this. And that's when I decided to incorporate medication-assisted treatment into my practice, and which later on transitioned into a full-on, we're at a behavioral health agency level right now in Pierce County, and we have 4 clinics. And my role as the Chief Medical Officer is to oversee all the medical staff and our policies and procedures, and maintaining a quality patient care and work environment.
Great. Well, tell us a little bit about, before you implemented Cordant's program, what would you hear from patients about them trying to get their medications filled?
Sure. So, we started, it's been almost 10 years that, this agency has been open. And when we started with the prescribing buprenorphine, what we noticed was that a lot of times patients would come back stating that either pharmacies don't carry it, meaning that they have to order it, and sometimes it would be back ordered. So there was always a few days that would be wasted when the patient wanted to engage and wanted to get a prescription for buprenorphine. So that was very, very interesting to us. So we contacted some local pharmacies. Unfortunately, a lot of the bigger retail pharmacies were either not interested in sort of hearing about the plights of a small practice and our patients. So we contacted some local pharmacies, and again, distance was a big issue, because for these patients, we have to understand these are not your regular primary care patients. These patients have lots of challenges in their lives. A big chunk of our patients are homeless, and more than half of our patients have transportation challenges. So for them to go to a doctor's office and then hear, okay, now you have to go to a pharmacy a few miles down to pick up your prescription. And then finally, when they go there, they're told their medication's not even in stock. So that's when we started, because our focus at NWIH is to really be that one-stop shop for our patients in recovery. We really, really focus on that multidisciplinary approach for this chronic disease and kind of removing barriers. So that's how we found out about Cordant, and then we were sort of interested, and that's how the whole process started.
Great, yeah, and that's such a common thing we hear all across the country. We operate a program now in 13 states. Across the country, and I would say universally, every state has its own little nuances and differences in terms of how they approach addiction medicine and the various regulatory issues in the state. But I would say almost universally, we hear from patients the stigma they face, the transportation challenges, even if they're relying on, say, Medicaid to transport them around, the challenges that can create if they have to wait at a pharmacy for medication. or like you said, pharmacies not carrying their medication and the challenges that creates for them. So that's, I know, very much true in Washington and Oregon, and really we hear it all across the country. So once we got the program running in your office, what kind of feedback did you start to hear from patients?
Yeah, Bob, it was really interesting because, as we said, anytime you start doing something new, and that also in the arena of addiction medicine, there's a lot of challenges, there's a lot of barriers to cross. So we were kind of skeptical, I'll be honest, initially, but it was really, really great because our patients started coming back with good feedback, that how the convenience of it, that purely it's becoming that one-stop shop where they come in, see their provider for the day, have their appointment, and their prescription would be ready right there. So that was really a sort of a very promising and encouraging thing for us. So we liked it so much that that's why we decided to put it to test. So and we decided to do the study with you all.
Yeah, that I remember the early days very much there, and we really worked through a lot of bumps. And you and your staff were great to work through that, and I'm glad we did. I think we were all skeptical whether or not we could make it.
You're right. Yeah.
Well, yeah, and like you said, that's what as you start to hear the feedback from patients, is that why you decided to dig in deeper to see, did patients just like it, or was it having an impact on outcomes?
Most definitely. So, not only that we saw, when we did the study, not only that we saw that it improved patient retention. So, we we had, I think, 156 patients and that we chose to study, and these patients were actually in their first 90 days of treatment. So that's when the patients are most vulnerable, we call it early recovery. So we saw that the overall retention in the program improved significantly. And not only that, we saw that these patients have fewer relapses, and you also have to understand that these patients are also high utilizers in healthcare all across board. So, when you have a 41% reduction in their overall utilization of ER visits, my gosh, I think that's amazing. And then 100% satisfaction rate for these patients.
Yeah, great. Yeah, it really was amazing to see the result. I remember getting the patient feedback that you mentioned, the 100% patient satisfaction, and being, oh, that's great. I'm glad they love it. I'm glad they like it. But is it just that they like it? Is it just convenient, or is it really making a difference? And then when we
most definitely in that stigma-free environment, because I hear this all the time from patients, that how they are reluctant to go to one specific pharmacy because they just feel that the pharmacist always just look at them differently, and they experience that stigma, meaning that they always feel like they're being watched, or they have to be like extra careful. And I think it's just unfair to our patients, because you have to also take into account that there is a huge lack of motivation in this patient population. So what we want to do is that we want to be supportive, and the way we kind of present it to our patients is that it's a journey in their recovery, and we want to be supportive. We want to be removing these roadblocks. So having the pharmacy on site was not only convenient, it was very safe, and the patients felt very comfortable that there was no stigma, no barriers, and it just worked very well for our patients.
Great. Well, Dr. Khan, thank you so much. Please hang tight. We will bring you back here when we open up for questions again in a minute. But let me introduce Chris Harlow.
Thank you so much, Bob. Thank you for allowing me to be here on this webinar today. I'm certainly happy to discuss the pharmacist perspective. So I'm a graduate of the University of Kentucky College of Pharmacy. When I finished my pharmacy school, I actually completed a community pharmacy residency focused in geriatrics, actually. So I'm a board certified geriatric pharmacist, and when I finished my residency, I opened up an independent pharmacy here in Louisville, Kentucky, and so we've really been starting a pharmacy focused on services, not just the products we dispense.
Great, Chris. Well, I know you have a very personal experience with addiction. Would you mind sharing a little bit of that with us?
Absolutely. So my mother actually suffered from a mental health disorder. Really was off and on treatment growing up, and so we were. I'm the youngest of three, and my siblings and I were exposed to mental health illness. She was very functional. She was able to hold a job while we were growing up, but once we all moved out, she ended up having a back surgery that led to opioid prescribing. Mm. And so she became addicted to opioid medication. Never really acknowledged that she had a problem with addiction to opioids. As the laws changed, it became harder and harder, more difficult to get opioid pain medication, and she ended up going to the streets for heroin and other substances. Oh. When I was in pharmacy school, I got the phone call when I was finishing my last exam that my mother had overdosed. And by the time I had driven back home, and the coroner was pulling her body out of the house. So, she had an accident overdose death that was really related to her started with her mental health disorder, and it was tragic.
That really is tragic, Chris. And did that event help shape the direction you took professionally?
Absolutely. I'm an innately passionate person. I love what I do. I was very excited to be able to become a pharmacist, but really her passing made me realize that there's so much more than I could do as a pharmacist. And I really, as I mentioned, when I started the pharmacy, I really wanted to focus on the services that met the needs of our community. What is it that our community needs, and what can I do to help shape that? And really reflecting on what I could do for addiction. As the laws were changing, we were able to dispense naloxone without a prescription. So I became the first pharmacist in Louisville to do that. And because of that, I was recognized by local leaders and the addiction community, and I really became that resource, that pharmacist resource for our community. And I even joined the Opioid Overdose Task Force here in Louisville.
Right. That's great. That is, getting naloxone out to patients with substance use disorder and their family members and friends that they're around is so important in saving lives. You mentioned that you believe pharmacists should be seen as a resource when it comes to addiction care. Can you tell me a little bit more about that?
Absolutely. So during my time as a pharmacist, I was also involved in our professional organization, and when I was president of the Kentucky Pharmacists Association, I was an integral part in the development of a regulation that allowed pharmacists to expand access to Vivitrol. And so we have a state protocol that essentially allows pharmacists to become providers and treat patients with an opioid use disorder that don't have access to providers. When, one of the services we were offering at the pharmacy was administration of Vivitrol. That is one area that we just couldn't find. Treatment centers were reaching out to me and they said, we can get Vivitrol, but we don't have the resources to administer. Can you do that? And I didn't hesitate. I said, absolutely. I want to be a site for administration of this medication if that's what the patients need. But what we found, and the challenges we really faced after starting that program, was the fact that patients, their refills would run out and we couldn't find them a provider so they could finish their 6 to 12 months of therapy that they wanted to achieve. So, and it's based on current practice guidelines. So we developed this protocol as a really as a way for patients to continue therapy and be pharmacist managed. So we were able to really work not just within the walls of our pharmacy, but we set up off-site clinics as well at residential treatment centers who were looking for Vivitrol providers.
Wow. Yeah, that's great. And I think you were one of, if not the only pharmacy in Louisville that was doing the injections at the time?
We were the only pharmacy in Louisville doing the injections. I was the first pharmacy in the state to implement the state-based protocol. I was the co-author of the protocol. So the day it passed our Kentucky Board of Pharmacy, the next day we had patients lined up ready to go. Yeah,
that's great, Chris.
There's a very high demand. When it comes to overcoming barriers, that's what we want to do. So, we face barriers every day, whether it's from not having enough providers, whether it's the payers or access to medication. We're gonna overcome those barriers, and that's the reason we even started our specialty pharmacy. We started out as a community pharmacy, but we opened a specialty pharmacy just for the access, right, from the payer side and the pharma side.
I love it, Chris. So if the policy doesn't exist for you, you just go out and write it yourself, right? And get it done. That's so great. And that overcoming those unnecessary barriers has really been such a hallmark of what Cordant has done, what St. Matthew's has done to try to help the addiction population. And it's, as I think Dr. Khan said, I mean, it's really sad what you see sometimes in the barriers that have been put in place, and sometimes often unintentionally, that we have to help our patients and our providers overcome. And that's what was so attractive about St. Matthew's, and why Cordant wanted to partner with St. Matthew's, is that it allowed bringing in expertise like yourself and your staff, and really allowed us to expand what we do beyond just buprenorphine into Vivitrol and other medications. So it's been a great partnership, and we look forward to expanding that across all of our markets. Well, thank you, Chris, for joining us. I'm going to explain Cordant's program just real briefly, and then we will sort of bring the panel back here and open it up for questions. So there's two sort of key points to our program that just will help as I explain it. Number one is that Cordant places a patient services coordinator, or what we call PSC, on site at your clinic to help facilitate medication deliveries to your patients. That's one of the core components of our buprenorphine program. And number two is you have the ability to use primarily one pharmacy, being Cordant, for the majority of your patients. Our program is completely opt-in, so patients are educated on the program. If they want to do it, they can opt into it. If they don't want to do it, they can opt out and continue using the pharmacy, whatever pharmacy they're using today. Or if they opt in, they can opt out later, or if they opt out, they can opt in later. It's completely optional for the patient. So when a patient first comes in, or when a patient enters their doctor's office that's working with Cordant, they get educated on Cordant. They're given some material. We tell them how the program works, and then the provider asks them if they would like to use our program. Again, that coordinates the delivery of the medication to the patient at the time of their office visit. If a patient says yes, they will, that same day, they'll typically go out to the pharmacy that they have been using, and the prescriber will send a prescription to Cordant for their patient's next office visit, if they believe the patient's going to be on the same dosage and frequency and all of that. We receive the prescription, typically as an e-prescription. Our pharmacy does a series of checks. We check the insurance eligibility, the PDMP. We check laboratory results if we're working with the clinic with their toxicology laboratory as well. If there's any irregularities or any concerns, the pharmacist reaches out to the clinic, talks to the clinician and the staff to talk about next steps. One of the things that our clinics really like about our program is that collaborative relationship between pharmacist and clinician, that there is a true collaboration there and true partnership there. And the consistency that comes with that too. They're working with the same pharmacy staff for most of their patients now, and that consistency really helps out a lot. We offer, as Chris referenced, naloxone to all of our patients, as well as we have a prescription drug take-back program that's been really successful. But if everything looks good, then we coordinate the delivery of the medication to our patient services, our patient services coordinator, PSC, at the clinic the same day that the patient's coming in for their next appointment. Now, if it's Vivitrol, we send the Vivitrol directly to the clinic and they take it from there. But for buprenorphine, that medication is sent to our PSC the day that that patient's coming in for their appointment. So if they're coming in today, Friday, and we know that they're coming in, they're enrolled in our program, the medication will be sent to our PSC, who will store it securely on site that day. The patient comes in, they see their provider, maybe they're doing counseling, whatever it may be on site that day, and then they come see us. And we give them their medication. It's already been dispensed. It's already in a white bag that they would get like at any other pharmacy. They sign off on it. They are offered counseling virtually with one of our pharmacists, and then they're done. And they can go on with their day. They don't have to coordinate that next step of getting to a pharmacy. They can get home to their kids, get home to work, whatever it may be, and get on with their day. To be really clear, we are not putting a pharmacy on site. That is not what we do. All of the pharmacy activity, the dispensing and the filling of the medication, putting it in the bag, the counting, all of that happens outside of this and at our brick and mortar pharmacy. We are simply coordinating the delivery of that medication to where the patient is going to be that day. when a clinic works with us, the office staff never touches the medication. They don't receive it. They don't sign for it. It's all handled by our PSC who's on site. We never keep any medication on site overnight. We're in network with almost all of the payers and all of the markets that we work with. And there's no additional cost or charges for the patients or the practice to use our program. Of course, normal copays apply, and we offer pretty competitive cash prices when that's needed.